How many hours of nutrition did you get in your training?
I completed my medical school in '03 and residency in '06. And if I add up the total number of hours between them, I think it comes to 0 or maybe half an hour.
Welcome to Culinary Medicine Recipe. I'm so happy you're here. I'm your host, Dr. Sabrina Falquier. I was a primary care doctor for 16 years and went to school for 4 years to specialize in culinary medicine. In this work, I get to combine my passion and expertise in both medicine and food to teach people about food as medicine and to empower them to understand what ingredients optimize health and also how to cook those ingredients to make delicious meals. On this show, I interview top chefs, doctors, healthcare visionaries, and food service professionals who are making great strides in the field of culinary medicine. Join me as we continue to explore the amazing world of culinary medicine, where I will empower you to make changes to your health and wellness with great food right away. Hi, everyone. I'm so excited for today's episode. I'm speaking with a seasoned physician and a medical student about their nutrition education, or lack thereof, and we're going to compare notes. Historically, physicians have received very little nutrition education, an average of only about 20 hours of total nutrition education in medical school from a 2010 survey, and a survey in 2023 found that just about 1.2 hours per year on average, with more than half of the medical students reporting no formal nutrition courses at all. So how do we get to a future state where food and nutrition are as much a part of healthcare as a blood pressure check? That line from the article published by Food Tank, titled Food is Medicine and the Future of Care Delivery, has been on my mind. That's the backdrop for today's conversation with Megan Roach, a third-year medical student at UC San Diego School of Medicine, co-founder of its first culinary medicine program and student interest group, recipient of a National Nutrition Research Award, and presenter of supporting research from these hands-on workshops at the Lifestyle Medicine Conference in November of 2025. Joining her is Dr. Thomas Carter, an internal medicine physician with nearly 2 decades of clinical practice and medical education experience, founder of Carter Medical Corporation in his hometown of Solano Beach, California, and the leader in bringing longevity-focused lifestyle management into patient care. Together, we'll explore what's missing, what's changing, and how food can become a standard part of medical care. I'm recently back from Pasadena, where I led 2 breakout cooking demonstrations for practicing clinicians at the Southern California Permanente Medical Group. The room reached capacity so quickly that due to fire code regulations, the number of attendees had to be cut off. They were physicians and health professionals already established in their careers, yet they listened with full attention, leaned in as I prepared recipes. Together we explored practical techniques for cooking, understanding ingredients, and becoming comfortable adjusting dishes for personal preference, allergies, and cultural nuances. So from the classroom to the clinic, the appetite for this work is undeniable. At UC San Diego, we run hands-on culinary medicine workshops for medical students. And when registration opens, it's 30 spots. It fills in under half an hour, and there's a wait list just as long. Students across healthcare, including future physicians, physician assistants, and graduate students, are eager to learn to integrate evidence-based nutrition and food into patient care. So the demand today is clear. Before we get into the conversation, I want to let you know that I'm hosting a Spanish language podcast about culinary medicine called Medicina Culinaria. It's already live with a season of episodes. If you know people or have patients or clients who'd be interested in hearing more in Spanish, please help spread the word about Medicina Culinaria. It's available wherever you listen to your podcasts, and the link will be in the show notes. Also, Alternative Food Network, which produces the show, has joined Buy Me a Coffee, which is a quick and easy way for our audience to support us. So if you love this show, please consider supporting Alternative Food Network on Buy Me a Coffee at buymeacoffee.com. That link is also in our show notes, and it's just a couple of taps. Now, on to today's episode.
I've had the pleasure of knowing Dr. Thomas Carter since we both did internal medicine residency together at UCSD a few decades ago. And Megan Roach and I have known each other creating and beginning the culinary medicine program at UCSD. So thank you both so much for being here. And I will say, Dr. Carter, I know your full credentials, but knowing how far back we go, I'm going to call you Tom if you're okay with that.
Yep, that works for me.
Okay. How many hours of nutrition did you get in your training?
I completed my medical school in '03 and residency in '06. And if I add up the total number of hours between them, I think it comes to 0 or maybe half an hour as far as nutrition. I think that we got a lot of information about maybe amino acids and carbohydrates and other things involved in biochemistry, but I don't remember discussing nutrition, at least not in any kind of structured way or in any way that stuck with me through becoming a primary care doctor.
So let's fast forward to present times, Megan. How are things now?
I wish I could say that a lot has changed. I think if I were to exclude the efforts that you and I have embarked on, it would be pretty close to Tom's answer, in that I think the beauty of medical school is that we have a lot of foundational knowledge, but the actual applied nutritional knowledge direct is pretty minimal. I think a couple of hours. I can remember a couple of lectures from our GI block and not much beyond that.
So why do you guys think that historically there's been so few hours in the curriculum?
I mean, I can speak to my remote experience at this point, and I think it just, those lectures were packed and lecturers were trying to get through a certain set of material that would be on the STEP exams or relevant to my, management of a hospitalized patient. So they really didn't focus on it. And primary care, I don't think in general was, or chronic disease management maybe a better term to use. Chronic disease management really wasn't something that was emphasized in medical school or residency. We're focused on acute care. We're focused on triage and admitting somebody to the hospital and then discharging them from the hospital.
Yeah, I'd have to agree and add on to that I think that people don't know what to teach, and for multiple reasons. One, because we're taught by doctors most of the time in medical school, and that's such a great thing, but it also means that if they didn't receive that formal training, then they don't feel comfortable unless they've sought it out themselves, unless they feel they're an expert in it. And most doctors don't, because of the lack of training early on. They don't feel comfortable teaching it. And then I think beyond that, there's so many applications of nutrition where there's not an agreement by research and experts and different diets. And so I think that disconcordance makes it so that there's not a curriculum for medical students.
You make such a good point, Megan, because it's such a generational. If the generation before doesn't have the skills, how are they going to pass it on to the future generations of physicians? Yeah.
And I would add, just not that they're just doctors, but they're also people. And most people don't have a good understanding of nutrition. They have their family recipes and they have their kind of go-to dinners or what have you, but they don't necessarily have confidence that they know what they're talking about, let alone in their own family or their own social dynamic. In front of a classroom, it's even more intimidating to sort of start spouting off about nutrition information.
Yeah, and I would add to that how there's such an experience of using anecdotal. So if you had a patient that had a success with a certain eating pattern, or a relative or yourself, that's the information that's passed forward rather than focusing on evidence-based nutrition. Now, Tom, why did you agree to come onto this episode?
I'm a primary care doctor, and now I operate a private internal medicine clinic. And so I have a lot of time, thankfully, with my patients now. But for the last 18 years, I probably had 9 to 13 minutes with them, independent of their medical complexity or their age or anything else. And so I always knew that nutrition education was something that I wanted to be able to provide and didn't have the time to do it. I now have the time to do it, and I'm still inadequately educated as to how to do it. And so I would say that the reason I agreed to come on would be I like the conversation. I think primarily what I'm noticing with my clients these days is that mostly they ask me what I do, like what do I eat, how do I exercise, and how do I live my life. And I'm trying to bridge the gap so that I can, educate and care for somebody, but also provide some window into my lifestyle. Frankly, I want to learn more too, to be a healthy individual. And so I agreed to come on because, we go way back, and I'm always happy to have a conversation with you, but also because I'm a perpetual learner in this area, and identifying the best ways to get across, reasonable, actionable information regarding nutrition is basically needed every single day that I see patients.
So Megan, what drew you? I still remember the day I met you when you and Akshara came up to me after a lecture and wanted to dive deeper into culinary medicine. I'm still in awe of truly how you ran with that. So what drew you to want to engage with culinary medicine and dive deep into working not only with me, but also with administration and colleagues and mentors to shape the beginning of culinary medicine at UCSD School of Medicine?
If I think back, that was such a great day. I was very enamored by you and the work that you do. And I think that it goes back to college for me, where I had some personal changes that I made. I saw a real change to my body. I was a runner in high school. I saw a real change to my body and like the way that I felt every day. I was getting sick all the time, and my grades were not great for my first year of school. And so I just think that once I started my sophomore year, I had room to cook in a house with friends and roommates that also wanted to cook. And we got really into that. And I became a vegetarian because I got deep in the Netflix documentaries and just wanted to do it for environmental reasons. And so we got super into plant-based cooking, and I noticed that honestly everything changed. My grades improved, my sleep improved, my social connectedness improved through food, and it just became such a joy for me that I had never had any formal expertise or exposure, and it just became something that I felt like changed my life. I was looking for that in my next phase of life and in my next formal learning opportunity. And I actually thought that in medical school I would learn all of that. And so I think that coming into medical school and realizing that wasn't going to be something that, yes, I would get all the biochemistry knowledge, but I wouldn't get this is how you counsel patients and all of the preventative measures. I was a little disappointed. And I think when I saw you speak, it really opened my eyes that people are doing it, but that we were going to have to seek it out a little bit harder.
There's a few things you just brought up. So number one is for a lot of us, whether it's a patient, and again, like you said, Tom, we're all people that eat, that there's often this awakening moment, and it can come from a personal experience. And I see that as kind of a target of having to think about ourselves and what change we do. And then if we see that change, then taking it outward. And that's what I have loved about what got you interested in this, and then taking it beyond yourself of realizing, how do I find this? And when you didn't find it in medical school, how do I create it, which is giant. What surprised you the most of the process of developing the workshops? And how have you found that these workshops are different than traditional kind of, you mentioned biochemistry a couple times, how that nutrition teaching that you've gotten?
I'll start with the obvious change between them is that there's the hands-on component. And that has been so crucial to get students involved and to learn like experientially, because that's not something that everyone feels comfortable or equipped to do at home. And I think that a lot of the reason that people don't have these skills is because it feels like there's such a barrier to entry. So I think that lowering that by offering some kind of hands-on learning with some supervision and teaching is crucial to people actually taking it home. Learning any kind of lecture, people are half listening and plan to go do more at home. But I think this is one of the things where you can't just go home and watch a video and just get it. It's something that you really have to get from being like, oh, I'm holding the knife this way.
There is added value, and really thinking of the teaching kitchen that we create as a learning lab, right? So we are learning these skills, we're learning about working in community. So yes, a lot of learning thresholds. If you had to guess, what percent of your peers or colleagues actively embrace food as medicine today?
Yeah, I think that there's a very low number of people that would disagree with the idea in, its conceptual form. The question is, do they apply it to their daily practice, I would think. And I think very, very few is the answer. And it's not because anybody's doing anything wrong. It's simply that it's not a skill set, and it's not something that's incentivized in large health systems or even academic medical centers where you're trying to work through especially in internal medicine, people with multiple medical issues and competing priorities.
All right. So, Megan, as you've gone through this process and now you've started to see patients in different capacities, what is one skill or concept that you learned that you wish every med student could take or that you have experienced now with some patients?
I think in a patient setting, I haven't had as much experience to bring up nutrition as much as I wish that I had. I'm pretty early in my third year, but I think in terms of culinary medicine in general and the skill that I wish I could have applied to all my classmates and honestly to all of the patients that I meet if we had the chance to speak about it would be ingredient preparation rather than meal preparation. And this is speaking mostly to like people who feel very busy all the time. And I think that's a huge barrier to entry for just cooking in general and having home prepared meals. And that's something that we've emphasized in the workshops of just preparing ingredients rather than entire meals. Because if you make one big vat of chili, like you said, and then you have to eat that for lunch and dinner and on repeat, and then you're sick of that recipe. And I think that can be kind of disheartening when you get up the courage to cook yourself a home cooked meal. So I think that's something that a lot of my classmates have struggled with, and just a lot of people struggle with in general, that I try to mitigate with just ingredient preparation and really looking at cooking as something that you get to do every day, but not something that you have to do that's going to take so long. So we've shown, preparing your greens and washing and cutting, and then preparing like a veggie saute, and then maybe some beans, or we've showed the ways that you can create various ingredients that are going to be quick to throw together, but in completely different organizations.
What I end up stuck on with patients oftentimes is they want to know what diet to follow, and they're not actually looking for nutrition advice or meal preparation advice. They want to basically sign up for a diet. Maybe they don't really want to, but that's what their friends do, and that's what their family does. They're vegan, or they're carnivore, or there's some infinite, derivation of either of those. And I think that becomes an identity thing oftentimes. And so the problem with diet as a term, and something I try to avoid talking about, is that people hold very strongly to the identity of being such a person, a vegan or a carnivore or a keto or paleo or whatever it might be. And so what I try to do is walk people back from that. And I think what Megan was highlighting, at least what I heard, was it's a skill set of being creative with nutritional ingredients. And those are common to all these different diets. They don't have to be dogmatic. You can get benefit out of some carnivore, some paleo, and some vegan. That's called a balanced meal, probably, But if you call it the Mediterranean diet, people will say, oh, yeah, I know that. I should eat olive oil and feta cheese or something. So I like to really emphasize the idea that this is a skill set, and the ingredient focus is really the important thing, because if you have it in the house, you'll be able to use it to create your meal. If you have a bag of chips, you'll be able to consume that quicker than you would ever create a meal. And so I try to focus on their habits, frankly, when it comes to shopping, when it comes to discussion of meal preparation. It's don't buy the thing you're going to consume if it's in the house, because willpower is sort of a fleeting energy. I try to focus on, okay, buy the stuff that would be good to eat if you end up eating it, and then next step, let's create some meals out of it. And I just appreciate what Megan said about that. Like, it is a barrier for people to start thinking about, oh, I got to have a recipe and I need a quarter teaspoon of nutmeg or something, I don't have nutmeg. Turns out the recipe is going to be pretty much fine without the nutmeg, like you can get 90% of the ingredients and you'll be all right. It's not about diet, it's about nutrition. It's about starting to get creative with the ingredients you have and setting yourself up for success by buying those things at the store.
So, coming back into the clinic for a bit, you may or may not be aware that there was actually in 2024, Dr. David Eisenberg of the Harvard School of Public Health, along with colleagues, published a new set of competencies in JAMA Network Open, looking at competencies to be incorporated into medical school curriculum. And The goal really is looking at nutrition to really bring it in, giving the language to medical students to understand, to be able to take it to the next step. So, Tom, when you look back, is there a skill that you wish you had learned? Like, if you had to say, okay, I'm going to have 4 hours of nutrition education or food conversations, what do you feel would have been kind of the highest ticket item on that list?
I mean, I don't want to sound flippant, but the thing I could have gotten the most out of, or the thing I would have received the most benefit from, would have been to be taught how to cook 5 dinners in a week within 20 minutes. Basically, the thing that most people are dealing with, which is the pressure of time. And maybe I don't need to know all the reasons why this particular nutritional component is so good for my mitochondria or what have you. I just need to know that this is a good choice, because that's human behavior. And if I can explain it to myself and make my dinner in a healthy way, there's a higher likelihood I'll be able to explain that to a patient or a friend who might be in need of it. If I become distracted and go down the rabbit holes of macronutrients, micronutrients, supplements, and all of those things, nobody's going to pay attention, at least not for very long.
So, going along with that, when we're now looking at ethics and food programs, how do you balance offering helpful resources without steering patients to one company or one product or one specific diet or a way of eating? And what are the ethical considerations that you take into account with this?
Here's the thing. When I was in residency, I had a clinic that was in a lower socioeconomic area of the county, and people really didn't have resources to go to the high-end grocery store or go to a restaurant where they're going to get a salad or something. And so I was always left with saying something to people like, don't eat white rice or don't eat tortillas. And frankly, I knew, because you can see it in their eyes, as soon as you say that, they basically tune you out, because that's what they're going to eat, And it's not because they're trying to worsen their diabetic control, but it's their culturally appropriate and important food. And so, the thing that I ended up learning was that instead of saying, don't eat this, don't eat that, I would try to offer alternatives, like more veggies instead of that pile of rice, or whole wheat versions of things. Even that didn't always get a lot of purchase, but at least it made it clear that I was trying to stay aligned with their what was important to them culturally. Nowadays, I don't worry as much about shying away from specific recommendations regarding grocery stores or products, because I feel like my main objective is to help my patients or clients actually do what they need to do. And the more specific you can be, the more helpful you can be. I think when you're dealing with the person in front of you, it's important to know where they live, what resources they have access to, and then do your research. Go to the store and figure out what do they actually sell there. And you can say, hey, on aisle 3, they got kale,
I love hearing how you transitioned. Again, you're in residency with not much education around this topic, and you are in the trenches now. Megan, do you want to add anything to this?
I do. I've just been loving hearing from both of you about how your focus is really less about what specific diet to prescribe or recommend. And I agree that it's really not about that at the end of the day. And that's great news for every physician who feels that they don't have an adequate understanding of which diet is better than another, because I think that at the end of the day, it's just about getting people to eat more of what's fresh and what brings them joy. And I think that really diving into what foods are comforting and which ones are comforting and good for you, and really trying to understand what is someone's health literacy, as long as you're trying to tailor it to your specific patient and their background. And that's something that we've really tried to do in our workshops, and something that I really appreciate too, because again, yeah, the Mediterranean diet is evidence-based, but it's really not that inclusive, and it doesn't apply to every food that everybody enjoys and grew up knowing. And I think that's one of the best things about food, is that people think about things that my mom made, or in our workshops we applied other cultural cuisines, and our entire premise is these are the Mediterranean diet principles, and here's how you apply it to other cultures. And we got feedback from students who wrote in saying, my mom made this, or my grandma made this, or I order it takeout. I didn't know that you could just make it. And food can be incredibly empowering to know how to make it yourself. And someone's relationship with food is just as important as what they're actually eating.
That is such an important point, and it applies to many different aspects of behavior change. I would say that not emphasizing getting down on yourself for lapses from whatever the ideal plan you had created at the beginning of the week is one of the more important things that I think I found in direct patient care. I think it's important to also, advocate for people to feel good about themselves in getting back on track after a lapse or after something that maybe doesn't meet the perfect nutritional guidelines. It's also, I think, really important to give people credit for small improvements and to encourage them to give themselves credit for small improvements. So if they go from eating out 7 nights a week to creating 2 meals in a week, that's a huge improvement. And that's sort of that, coefficient of static friction or whatever the term was in physics, where it's the hardest thing to overcome is that inertia of never cooking to cooking just a little bit. And if they can do that, just like if they can go for a 1-mile walk or a 10-minute jog or something like that, they've started that process of habit change. And that's really what human behavior is all about. That's where I try to lean in and I say, great, you made 2 things. What were they? I'm interested to learn. And again, asking and being curious is more valuable than lecturing and saying, hey, you got to, eat this many carbs and grams of fat, et cetera.
How realistic is it for a clinician to give practical food or meal advice in a 15-minute visit? Tom, I'll start with you since you've had many decades of experience with this.
Geez, many decades. I've had a couple of decades of experience with this type of visit. I've chosen a practice now where I have a little more time, which I appreciate, but I can still tell you that there's never enough time to fully address every issue that a person wants to discuss or needs to discuss. And so the strategy that I encourage amongst other physicians and residents and medical students is not to try to solve the problem in 15 minutes, but to simply start the conversation. Because at least in primary care and in many specialty clinics where they're seeing people over and over again, these are conversations which can occur over and over again and progress over the relationship with your physician. And I think that's the most valuable thing, is that if they have consistency, if the patient comes in and knows, oh, Dr. Carter's probably going to ask me how I'm doing with my nutrition, I better have a recipe this time that I know what to tell him, because he keeps asking me, what's the recipe that you're going to make tonight? Which is the thing I ask. I try to ask a specific question. And so I think iterative, repetitive questioning over multiple visits about what people are eating or what they are going to make that night is actually my biggest recommendation, just like it is for exercise. What is the exercise you're going to do today is the question, not in general, what do you do for exercise? Because then people say, even if they're 60 years old, oh, I played high school football, I'm like, well, great, but
that was a few decades ago. That one's definitely
that's not relevant anymore, Or I used to be a vegan 4 years ago. You're like, okay, well, what are you going to make for dinner tonight? That's really the question. And so to get back to your question, 15 minutes is inadequate to address fully anything, any topic. You can do tactical addressing of certain things that are acute. You can check some boxes, but what you really need as a physician, I think, to get comfortable with is that these are longitudinal conversations that are occurring in 15-minute increments over a period of 10 years, and so or more. And if you do that, then their relationship develops, and caregiving is about relationships, and nutrition can weave into that just like all other aspects of that physician-patient relationship.
Do you want to reflect on that, Megan, as starting this journey?
Yeah, I mean, I love that approach. I think it's very inspiring to, we learn about the basics of motivational interviewing. That's something that medical school does really touch on because it comes up in so many different aspects. And people really have it dialed with smoking cessation and exercise, but then it does seem like with nutrition, we shy a little bit further away. And I want to touch on the fact that I think the beauty of, although you can't fit an entire overhaul or an entire, deep dive into someone's relationship with food or habit changes in 15 minutes, I think you can touch on it. And I think that continuity is important. But even just for people that don't have that privilege of continuity, I think it's worth it because I think people want to know that their doctor cares. And the beauty of culinary medicine is also that it's interdisciplinary. And I've been in many settings now where actually the dietitian is leading that conversation, but the physician is beautifully teeing them off because we learn about, real blood pressure changes when a physician walks into the door and things like that, white coat syndrome. People do care about what their physician says. And I think being able to reinforce that with other members of the team is really important. And it just gives people more touch points.
So as we're closing up here, is there anything I didn't ask you that you wish I had? So please share that. Or what's one thing that you hope med schools do differently in the next 5 years?
Your question about what do I hope that med schools will do differently in the next 5 years tees us off very well from the conversation we were just having, because I do think that my biggest passion about our project with the workshops has been that I really have wanted people to focus on themselves first and really build that skill set for their own weeknight, dinner, and feel more comfortable with it themselves, because it's such an element of wellness. It is one of the biggest ways that I stay well, and I just find so much power in that, and being able to do that and not feeling helpless in, creating a meal that makes you in turn feel really good. I think that component of wellness is something I hope gets integrated into medical schools, because they are so passionate about wellness. And I think there's been many conversations from the medical school even asking us, and I really commend UCSD for asking students, like, what do you want your wellness to look like? And I have raised my hand in a big auditorium and said, I think we need more culinary medicine. And I hope that they take that and run with it eventually, but that hasn't happened yet. But I think that they are starting to realize that if you can do it yourself, then you can help patients. And we're starting with that first step. And a lot of my classmates have actually really bought in. And I've been getting texts like weekly to monthly of somebody sending me a picture of something that they made and saying, look how good this looks, or I was inspired by you or your workshop. And it's just been such a joy to see people just take it for themselves. And I care about the patients too, but right now my goal is to really get people to incorporate that into their own lives and then feel confident with just sharing it with a patient like they would share it to a friend.
As far as a closing reflection, this is really fun, and I hope we get to keep having interviews over podcast. Thank you. And I think a reflection is that we're really all just trying our best for the most part, I would say. And it doesn't really benefit anybody to pretend that you're an expert in something you're not an expert in. And I think that took me a long time to let go as a professional physician, because there is this sort of attitude that people are coming to you for knowledge, for your experience, and for you to basically give them the answer. I think that's maybe a relic of my educational time and yours, Sabrina, where we were essentially rote learning and spitting it out and memorizing mnemonics so that we could get all of the criteria of acidic fluid and pleural fluid right, and that Krebs cycle that I kind of distantly remember.
Don't remind me.
I don't remember the Krebs cycle, so hopefully I can reassure you that you will not need to know it at some point. I've never said ATP in the clinic in my entire life, so just so you know. And I think that I would hope, and I'm a clinical faculty member at UCSD, and I'm hoping to impart this sort of attitude over time as well, that there is a role for knowing that information for a period of time, but really the art and the practice of medicine is about partnership with other human beings. And so learning the skill set to live your own life in those ways is probably the most powerful way you can help others, because that's how we teach each other. We teach each other what we do, and they see us as examples. It's something that I think about because I do now try to live in the way that I ask my patients to try to live. And I think we just have to understand that that could start way earlier in medical school, even earlier probably. But as you arrive in medical school, I'd love students to be able to be encouraged to learn a few good recipes and to learn a few good exercises and maybe some creative outlet like reading a novel and other things that are good for your brain in totality rather than just cramming information.
So, Tom, how can people reach you?
I have email. My email is tom@cartermedicalcorp.com.
How about you, Megan?
I'm very passionate to share, and the best way would probably be email right now because I am checking it all the time. So MEROACH, Roach like the bug, at ucsd.edu.
Perfect. Thank you both so much. This was really fun, and I really love to hear the conversations of us in very different stages of our career journey. So thank you, Megan and Tom, for this time together.
Thank you, Sabrina.
Thank you.
Today's conversation with Megan Roach and Dr. Thomas Carter highlights both the progress and the gaps. We see the hunger for culinary medicine from students who sign up within minutes for culinary medicine workshops, and from practicing clinicians who fill every seat of cooking demonstrations to learn new skills. We also see how little formal nutrition education most physicians still receive. We're beginning to see signs of progress, though, with Congressman Jim McGovern has spoken out in support of nutrition education and medical training, and the Eisenberg competencies have been published, and some medical schools offer formal electives or even full courses in culinary medicine. But we're not there yet. To truly transform care, every medical school graduate, regardless of specialty, needs to leave with practical nutrition knowledge they can carry into their own unique practices. Until next time, salud and bon appetit. All content provided or opinions expressed in this episode are for informational purposes only and are not a substitute for professional medical advice. Please seek advice from your doctor or other qualified healthcare professional.